Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
The blood pressure cuff is applied to the forearm so that we can then use the sphygmomanometer to determine the blood pressure before we administer anything intravenously. The cuff is applied above the antecubital fossa, and this leaves the antecubital fossa then exposed for auscultation. The sphygmomanometer is here. The valve control is tightened up in the usual fashion, and the cuff is then inflated. We place the stethoscope in our ears and use this diaphragm for auscultation to listen for the first pulsations of arterial pulse and then for the muffled sounds of the diastolic pressure. So we'll first inflate the cuff, and as we do, you can see the veins here distend a little bit already. We'll carry this up over 200 and then let it go down gradually, applying the diaphragm here and listening for the first systolic pressure. As that comes in, the needle moves a little before we can hear anything. Now we pick up the first sound of systolic pressure. We continue to deflate the cuff gradually. The audible pulse becomes much stronger and then suddenly is muffled. And in this blood pressure determination then we found a systolic pressure of 122, a diastolic pressure of 78. And that would let us know where this patient is in connection with anything that should arise in the way of an adverse reaction to any drug that is given. Adverse reactions are extremely important when one considers the intravenous route because they are so rapid. We'll be reviewing the anatomy and the physiology of the intravenous administration in a moment. The anatomy of the antecubital fossa finds an area which is readily accessible, which has superficial venous distribution, and that venous distribution anatomically is quite variable. Beneath the skin and superficial fascia, we find the veins coursing upward in a common course for which we will turn to an anatomy reference. We see in this anatomy textbook drawing the skin and superficial fascia removed from this segment of the forearm, exposing the structures beneath the superficial fascia in the antecubital fossa, which is our target for the intravenous route of administration today. We will see the course of the veins coming up from the hand then and having these anatomic variations, coursing in general along one of two pathways, either the cephalic vein route in this manner or crossing over here commonly in the antecubital fossa, and the larger basilic vein is seen here. Among the anatomic considerations that we will have in mind will be the proximity of the artery, which is immediately adjacent to the nerve at this point, and also these cutaneous nerves. We see here the medial cutaneous nerve of the forearm coming down and having a very intimate relationship with the vein at this point. This can give rise to some complications of disturbed nerve supply, and so we want to get to the exposed areas of the vein and make sure that we locate a vein in this particular fossa. Physiologically, we will recall that the blood is being carried back from the extremity toward the heart and coursing along these veins. Anything that we administer in this vein at this point is carried then very rapidly to the heart in approximately 10 seconds to get to the heart. Then to get to the lungs, back to the heart, and up to the central nervous system to the brain takes approximately another 20 to 25 seconds. So roughly between 30 and 40 seconds we will get an effect on the central nervous system from any agent that we administer here. The potency, therefore, of that route has to be considered pharmacologically in any agent that we administer. And it's important, therefore, that we use appropriate dilutions and rates of injection as we're injecting things into the vein. We will consider also the concentration of anything there due to the damage that can occur to the vein wall, about which we'll speak a little bit later. The technique of intravenous administration is simple. We will try to show the means by which we can facilitate this entrance of a needle into a vein. First of all, the vein must be dilated. To be dilated, it has to be carrying adequate blood. So we'll first increase the blood to the extremity by holding it down and asking the patient to open and close the hand. This flexion of the musculature pumps more blood into the lower part of this upper extremity, and therefore it will automatically increase by gravity. The dilatation of the vein will fill more blood in this extremity. To further dilate the veins now, we'll have the patient hold a tight fist, and that will make the underlying muscle bed firm and hold the veins upward. We'll add to that the application of a tourniquet at this point above the antecubital fossa. The tourniquet can be any elastic band-like material, such as this old plasma tubing, in which we can apply it above the forearm. We'll go over this slowly in an attempt to demonstrate how the tourniquet is applied. The tourniquet is crossed. The finger of one hand is placed underneath the crossed tourniquet and then stretched, and the end is picked up like this and tucked underneath in this manner. That tends to hold the tourniquet in place so that if we wish to release it rapidly, which we will do as soon as we're in a vein, we can simply pull it like that. We'll go over that again in a moment as we're demonstrating the technique further. The armamentarium for venipuncture is very simple. We have the tourniquet, as we have mentioned. We prepare the skin through which the needle is to be placed with an alcohol sponge that we'll show here in a moment. We have a disposable needle and syringe here, a 21 gauge needle that is wrapped in this manner and it's been autoclaved. It has a housing which protects the sterile needle and a plunger here that we will also demonstrate in a moment. Insofar as the actual technique of the penetration of the skin and vein wall by the needle, there are only two things that are variable. One is the angulation of the needle. The other is the position of the bevel of the needle. And with some simple diagrams, we'll try to demonstrate those variables. This drawing will illustrate angulation at which the needle penetrates the surface of the skin. We see here a penetration that is made with the needle held quite flat, nearly parallel with the skin, and this is used for making very superficial injections intradermally or in the skin layer itself. Here we see a perpendicular angulation of the needle to the skin that is used when complete penetration is desired if an injection is to be made deep into the muscle. Here we see the angulation of approximately 35 degrees to the skin surface that is used to make the penetration through the entire skin and to get into the vein itself. We go in at this angle through skin, and then once we're into the skin, we make the needle a little bit more parallel to the surface as a second thrust is made through the vein wall, which we will demonstrate. The bevel of the needle has importance when we consider the matching of needle size and vein size. If we have a needle that is large in caliber and a vein that is relatively small, one must be particularly careful about the needle. If the needle is small and the vein is large, then the bevel can be held upward in this manner as one goes through first the skin and then the vein wall. Here we see then the needle lodged within the lumen of the vein. Here we see a situation where the vein is small. When the vein is small or the needle is large, that means that we would wish to have the bevel down. That does not permit any leakage from around the site of penetration as we go through, as we will next see in this drawing. We will see here that with a large needle and a small vein, that the needle makes an incomplete penetration and allows the leakage of blood then out of this vein if the bevel is up. If the bevel is down, as we see here, the penetration then is complete into this smaller vein and does not permit leakage around the site of penetration. We wish to avoid such leakage, and therefore we watch the bevel of the needle as we're making the penetration. If it's a large vein, the bevel can be up. It's only when we're going into small veins with large needles that we consider the bevel down technique. We'll now return to the patient and illustrate the venipuncture technique. In order to prepare the skin before the penetration with a needle, we utilize an antiseptic sponge. This is an alcohol sponge, which is wrapped and is used for that purpose. We'll just open it and have it ready, and when we're ready to make the penetration, we recall that the needle has had its sterility preserved by this housing. We'll make sure that housing is loose so we can get it out rapidly when we want to. The purpose of the hemostat is simply to hold the needle if we wish to change the syringe after the needle is in the vein, with the administration of a different fluid or hooking up to a bottle, as we'll show a little later. The Band-Aid is here to apply after the venipuncture has been completed. The tourniquet then is applied to the arm as we previously demonstrated. With the hand down, flexed, the tourniquet applied as we illustrated before, crossing it, placing the finger underneath the cross tourniquet, taking this end and tucking it underneath as the loop is pulled out so that retains itself well and can be rapidly released. We ask the patient to keep the fist clenched, and we support the elbow here so that the operator's hand and the elbow are all in one position. We'll take the alcohol sponge, prepare the skin by rubbing it vigorously over this area, then letting it dry a little bit, air dry, so that it will not be too slippery. We take the needle from the housing and we support the skin with the thumb. Now the target for penetration is about up there, but our skin penetration is made below. So we support the skin so the needle doesn't shove the skin, and we make our penetration then at the angle that we illustrated and go first only through the skin, parallel with the vein, but not into it. Now we're under the skin, and we'll change the bevel, angle, and aspirate as we then go into the vein itself. And if you see the syringe filling with blood as the negative pressure is achieved. Now we don't need blood. We'll ask the patient to relax his hand, and if we were going to administer a drug now, we would take the tourniquet off, of course, in the rapid release that we talked about, and we then would administer whatever agent we were going to need. In this instance, I'm simply going to shoot this collection of erythrocytes back in because we don't have any need for it for any purpose, and we're not going to give this patient any sedation, anesthesia, or intravenous fluid. Now that we are about to remove the needle from the vein, we'll place pressure over it, and this sponge again, placed over the venipuncture site, is firmly held in position, and the needle is rapidly exited, holding pressure then on the site of the venipuncture. We ask the patient to continue some pressure there against that vein wall while we get our trusty Band-Aid ready and apply it over this not too large or purple-hearted wound. And then we'll remove the paper from the adhesive on the Band-Aid and get ready to apply it over the area of venipuncture. We'll remove the cotton and apply this one side at a time, stretching it. If there's any tendency for leakage from this site of venipuncture, we'll ask the patient to elevate the extremity, lift it up in the air for a time to reduce the flow of blood to that extremity and therefore reduce the pressure on that hole that we made in the vein. These holes ordinarily seal up very rapidly. The complications of venipuncture and the administration of agents intravenously should be infrequent. We've already mentioned some of them that relate to mechanical complications, namely the fact that there may be leakage after the penetration has been made into the vein if that wound does not seal off rapidly. We've indicated there could be mechanical trauma to adjacent nerves around this region. The possibilities of instituting an intravascular thrombosis at a site of irritation within a vein is another of the complications, which even becomes more severe if it becomes infected and one gets a septic thrombophlebitis. Perhaps the most serious complication of all is the accidental administration of an agent into an artery instead of into a vein. This misadventure causes then the rapid transport of that agent down the arterial system, down into the hand, where along the way it produces a serious vascular spasm which cuts off the blood supply to this lower hand area and can induce gangrene as a complication with loss of the hand. Such complications are reported. This complication should be very infrequent. The possibilities of injecting into an artery would be foretold by the density of the arterial wall, which is thicker, more muscular than the venous wall, more difficult to push the needle through. When one aspirates, you do not need the negative pressure to get blood back from an artery. It literally bounces back into the syringe, and when it does so, it will be a bright red color rather than the dark venous blood that is seen in the ordinary venipuncture. With the needle in an artery, there also may be some bouncing from the pulsations within the artery causing movement of the needle. These signs, then, should be ample warning that the needle is not in a vein and is in an artery from which it should be removed as quickly as possible. These, then, are a few of the potential complications of the intravenous route. There are some obstacles to the technique of venipuncture that we can consider. There are a few obstacles to venipuncture which relate to mechanical problems. These are any movement. It's obvious that the target must be fixed. If there's any movement of the arm, there is difficulty in controlling the maneuver. The skin in this area may be quite thick with a fair amount of adipose subcutaneously, and rather obese older ladies are difficult to establish an intravenous route because of the camouflage of getting through there and finding a vein. The pigment of the skin may serve as another camouflage, dark pigmented individuals having less visible venous patterns. Children have very small veins that are thin-walled, and these too may be difficult to establish an intravenous route. We have indicated that the intravenous route is relatively simple to achieve. We have indicated that it is very useful for the administration of emergency drugs and should be established where a patient requires resuscitation and is not coming around, we've indicated that it is useful for the administration of agents for premedication, for analgesia, and amnesia, and other forms of anxiety and pain control. We've suggested that there are a few complications, but if one follows a simple technique, stabilizing the target area carefully, making the penetration with the prescription that we have outlined for you, that this is a means through which you may supply a life-saving avenue for the administration of drugs.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.